Good afternoon, everyone, and a very warm welcome. Dear colleagues, it's a great pleasure to have you with us on board today. We are very happy to begin this journey together, sharing knowledge, experience, and practical insights that empower us all to provide better menopausal care. Welcome to the first in an exciting new series of monthly webinars hosted by IMAS. My name is Marina Šprem-Goldstein. I'm gynecologist, subspecialist in human reproduction and gynecological endocrinology, full professor at Medical School University of Zagreb, president of Croatian Menopausal Society, also head of Department for Human Reproduction and Gynecological Endocrinology, Zagreb, Croatia, and finally, EMA's board member. We are delighted to have you join us today and look forward to sharing these insightful sessions with you. It is my great pleasure to chair today's session on weight gain and metabolic health in menopause, a multidisciplinary approach. This webinar is designed as a practical and evidence-based guide, offering insights that clinicians can easily apply in everyday practice. We are kicking off with one of the most common and often most frustrating challenges clinicians have worldwide: weight gain and metabolic health in menopause. Today's webinar brings together leading experts to turn science into practical strategies, bridging the gap between research and real-world care. There will be two insightful presentations followed by an opportunity for you to ask questions and engage directly with our speakers. I am very delighted to welcome two distinguished experts joining us today. They are both from Croatia. Our first speaker is Dr. Davorka Herman. She is a subspecialist in endocrinology and diabetology, working at the Department for Human Reproduction and Gynecological Endocrinology at the Clinical Hospital Center Zagreb, Croatia, where she focuses on endocrine disorders, obesity management, infertility, and metabolic diseases. In addition to her clinical work, she serves as a teaching associate in both undergraduate and postgraduate programs in gynecology and obstetrics, as well as in occupational and sports medicine. In addition to her clinical work, Dr. Herman serves within the Croatian Olympic Committee, where she oversees healthcare-related areas and contributes to strategies that support health, prevention, and optimal long-term well-being. This dual perspective, of course, from everyday clinical care to elite sports, allows her to provide a comprehensive understanding of health, prevention, and lifestyle medicine. In today's lecture, she will share insights on weight gain in menopause, highlighting practical, medically grounded strategies and drawing on her extensive experience in both reproductive and metabolic health. She will explore the topic of weight gain after 45. Is it inevitable or preventable? It's a very important topic, which is very interesting for many women and also, of course, for clinicians. So without further delay, I'd like to invite Dr. Davorka Herman to begin her presentation. Davorka, the floor is yours, and we are eager to hear your valuable insights and experience.
Thank you very much. Thank you for your kind introduction. So the worst part for me is done. I hope I'm sharing the screen. Well, if we talk about weight gain after 45, I have to say that many women feel betrayed by their bodies because they come to me and they say, okay, I'm doing everything I used to do, but it's not working anymore. I'm gaining weight. There are some great women today. One of them is Dame Helen Mirren, who said life doesn't end with menopause. It's the beginning of a new adventure. Strap in and enjoy the ride. But the problem is that the ride might be complicated by the kilos. Actually, around 43% of menopausal women have obesity. And the most rapid changes in body really occur at the age of 45 to 55. And that's something that we have to insist on talking about and not being in the situation. The key question remains, is weight gain biologically inevitable or clinically preventable? Changes in body composition are alike changes that come with aging. Actually, there is an increase in fat mass and a reduction in lean body mass. And then when we talk about it, we have to mention the basal metabolic rate, which is something that is commonly known as metabolism, because this is the energy spent just by existing of the body. And the problem is that lean muscle mass spends many more calories comparing to the adipose tissue. And this is why when we have this shift towards the fat mass, the basal metabolism goes down. And this is the major problem, which is not only hormonally influenced, but definitely there is the influence on the hormones, but it's also the way that human race age. If we talk about central control or the control of the energetic balance, everything happens in the brain. It all starts and finishes in the brain. There are many hormones, mostly in hypothalamus. They are active. There is a really vivid interplay in between those hormones. But we should not forget that sex hormones are active in the brain as well, also playing with all those factors which lead us to reach the satiety moment or to be hungry. And if we look at estrogens, they decrease appetite, they decrease food intake by these central mechanisms, and also decrease body weight and promote subcutaneous distribution of fat. So what happens in menopause when you don't have any more estrogens? Well, we have this shift from subcutaneous adipose tissue, which is something which is good, which is protecting us, where hormones grow from, so that's something we like. But we're going to the visceral, which is not only the aesthetic problem that we have around the belly, but also serves as a great cardiovascular risk factor in women. Causes of obesity in postmenopausal women are many. Usually, women tend to see that something is changing in perimenopause, so basically a couple of years before menopause even starts, and roughly it's around 0.5 to 1 kilo per year. Many factors. Genetics is something we should not forget. So if we have obesity in parents, there is a great chance that the woman will have obesity as well. And also, this is the phase of life when we have some chronic diseases occurring, such as hypertension, type 2 diabetes, musculoskeletal diseases, and they all have medication. And it's really important in 21st century to choose those medications who will not get the extra weight on. That's especially when you talk about diabetes, we can today really choose wisely talking about medications. There are many factors affecting menopausal obesity. Physiological factors, there are some fun facts which are not so fun, which is like the decrease in basal metabolic rate 1 to 2% per decade after the age of 40, decline in muscle mass 1 to 2% annually after the age of 45, muscle strength, so it makes it harder to be active, 3% annually, and also musculoskeletal disorders and some other diseases that come along. If we talk about hormonal factors, there's hypoestrogenemia, hyperandrogenemia, vitamin D deficiency, all leading towards obesity. Lifestyle-related factors, if we look at it, there are some things that we can do when we are young, but pay time comes in menopause, and we are used to having excessive caloric intake, low dietary fiber intake, excessive sugar intake. We eat large portions, we eat processed and convenience food, smoking, alcohol consumption. It all comes to payment in menopause. Together with low physical activity and sedentary behavior that we usually bring to menopause, and of course, irregular sleep. So if you think about marketing of the food industry, you always see things like 10% bigger, 20% bigger, you pay one, you get two. Then we have some kind of impression that they're giving something to us, but actually they're taking our health, and that's something that women should take care of. Also, the psychological distress and all those situations that come along as we age. If we go to physiological factors, I would again stress out the muscle mass and the decline that happens in as we age, but especially in menopause. and also the physiological causes that we combine with some other factors. One of them that I like to point out is PCOS. So basically, we leave over polycystic ovary syndrome in reproduction, and maybe in menopause it's not a reproduction issue anymore, but there's a metabolic one which is even greater and even more dangerous for a woman. So I think that most of the menopausal women will not get the question, did you have PCOS? And that's something that we should think about. But if we talk about physiology, age is a factor, but lifestyle is strongly magnifies this effect. So everything we do can change a little bit or make a positive shift in physiology. How does it happen? Well, there is a Simpson theory. It was the author who talked about protein leverage effect. In menopause transition, low estrogens and intermittent high FSH enhance muscle breakdown. So there is the increased protein requirement. If we listen to it, so if we actually take the extra proteins we need, then we can save the muscle mass. But usually women do not do it. They don't go up with the requirements. They stay as they were or go lower with what they consume. And then hunger somehow shifts towards the appetite to fat and to carbs. And this is how we have the loss of muscle mass. Actually, weight gain and lean tissue losses might be even prevented by a small adjustment upwards of only 1 to 3% in dietary protein concentration. Psychological factors are many. Menopausal women report high prevalence of negative emotional state, such as depression, stress, anxiety, tension, sleep disturbances, and sexual problems. And it all changes also the body image issues. And then what do we do when we are stressed? We have emotional eating, and emotional eating is never for a healthy thing. So basically, when you're nervous, you don't feel like eating an apple. You feel like eating a donut. And that's something that, puts on the calories, and the story goes towards obesity. When talking about obesity, I always imagine vessels. I'm a diabetologist, so when I think about diabetes, when I think about obesity, I'm trying to, change my direction from the lab tests and from the weight and some kind of numbers. I always try to imagine blood vessel, endothel, inflammation, and what happens there. And really, obesity, in the same manner as does type 2 diabetes resistance through free fatty acids, TNF alpha, interleukin 6, they all do the inflammation on the level of endothel, which is then suitable for the formation of the atheromas, of plaque and of thrombosis of cardiovascular diseases. And so we're definitely shifting away from obesity as an aesthetic problem towards the cardiovascular risk, which is huge when you have it. So what can we actually do about all this I stated? Is it really inevitable? Well, it's common, but it's not physiologically mandatory. And the fact is that women who engage in structured lifestyle intervention maintain or even reduce weight through menopause, but the key determinant stays the preservation of lean muscle mass. If we talk about obesity management, it's always the same, whether you are young or you're in menopause state. There's always this, we always insist on lifestyle changes. So living the healthy life, that's something we cannot, there is no pill, especially today in the era of medications for obesity. We should never forget the lifestyle intervention, because that's the foundation of everything. Behavioral modification, then pharmacotherapy, usually with the BMI over 27. If there are some related complications, usually women in menopause have something, so we are usually here. And don't forget about bariatric surgery. That's not something which is reserved only for young people. This is something that we can use to help our patients even in menopause. There are documents of EMAS, there are documents of other associations. They all stress they point out the importance of obesity in menopause, and of course of the lifestyle interventions and what we can do before it even starts. So we should adjust diet composition. We should focus on high protein intake, plenty of fruits, vegetables, whole grains, and reduced added sugars and refined carbs. That's something we should actually do all throughout our lives. Proteins are the one, as we already showed, that will protect the lean muscle mass. Limit alcohol. When we talk about alcohol and menopause, it's usually the talk about hot flashes, but actually here as well, because alcohol brings the only calories that the body cannot use for energy, just for fat, and that's something we should know. And maybe I'm proud to be, one of the many things I'm proud to be Croatian is the Mediterranean style food, because this is how we used to eat. Unfortunately, the less and less, but we have some basis, and it shows to be the best metabolic outcomes in European data. Menopause is usually the time when we can start counting calories. People who don't have obesity don't usually count calories, and it's hard to say how many calories they eat per day. But this is maybe the phase where you should start thinking about 200 less than usual, or to adjust calories in a way that there are small gradual changes in caloric needs, approximately 150 calories fewer per day per decade. So maybe, when talking to our patients, there has to be some kind of restriction, that's for sure. Do we like to call it calories? Do we like to call it piece? Do we like to call it grams? It's not important. It's important for us, our patients, to understand it and somehow to make it applicable for their own lives. Foods to avoid are always the same: pastries, fast food, and candies. So all of them have a lot of sugars and a lot of salt, which is hidden in it. But something I like to talk about is added sugars, or what we call hidden sugars. Those are those sugars that we bring into our bodies without really thinking about sugars. Mostly, about half of it comes from sugar sweetened beverages, such as soft drinks, flavored things. Flavors are usually sugars. Coffee with sugar is sugar, it's not coffee anymore. Tea with sugar is sugar. So that's something that we should change in, if not earlier, then definitely in menopause. There are some predictions that an average American takes about 300 calories a day in the average with hidden sugars. I don't think that it's a lot different in Europe. Move more. We should include both resistance and aerobic exercise because they help preserve the lean muscle mass, and they slow the metabolism. In that way, when we preserve the muscle mass, I will remind you, we will preserve the resting metabolic rate. The recommendation is at least 150 minutes per week of moderate aerobic activity, which means walking, and 2 sessions of strength training recommended. We are, especially, being in sports, we see that even in recreation, we are moving from aerobic, jogging, running, things which were some kind of fashion like 10 years ago. Now we're talking to strength. And when we talk about cardiovascular predictive models, one of the very important things in our body is the mass of quadriceps, of the muscle of quadriceps. So strength activities are very, very important. Of course, don't forget about the activities that relax, such as gardening, yoga. Although they always say it's relaxation, I think that everybody who tried it will see that it's not so relaxing, it's hard. But some other hobbies which include moving and are relaxing. Sleep is very important. I will remind you that the human species can go longer without food than without sleep. When we don't sleep, there is a low elevation of cortisol, which can promote, again, abdominal fat. So mindfulness, yoga, consistent sleep routines are protective, and it's all coming in the combination with exercise. So if you move more, you sleep better, then you can get easier to exercise more, then you sleep better, and this is a circle which is very positive in one's life. If we talk about medical therapy, I think that Ivan will talk about hormone therapy, but that's something which is proven to be good. The things I like to do is GLP-1 receptor agonists, because they are the drugs which are created for treating obesity, and they promote satiety, reduce calorie intake, and help with sustained weight loss. And the effects in postmenopausal women are similar as any other age in life. Some of them may lower cardiovascular risk, which is something that we have to stress out, and it's choose wisely, choose the ones that have proof that they have this protection on cardiovascular system, and always stressed that lifestyle interventions are important and that we should combine them with resistance training and adequate protein intake, again, in order not to lose the muscle mass, which is something that we tend to lose when we're losing weight by any mean. The combination is great. So hormone therapy and GLP-1s, it's a perfect, match made in heaven. But I have to stress that it has to be done under medical supervision. Why? Because I think that today we have the soya drugs, and we have influencers on the webs telling us how to treat obesity. It's not complicated to start, but managing the side effects and how to go down with drugs, that's something that you should really discuss and do under medical supervision on somebody who knows how to do it. So to conclude, key takeaways: weight gain after 45 is not inevitable, it's modifiable. Changing the diet and exercise habits is weight gain. Maintaining muscle mass is central to the prevention, and always think about the muscle. And lifestyle interventions must be individualized according to what somebody likes or needs, and culturally adapted across regions. And please commit to lifestyle changes and enjoy a healthier life. Thank you.
Thank you very much, Davorka, for your excellent and very practical presentation. As I mentioned before, we'll take all questions after both presentation during the discussion session. So now it's time to present our second speaker, Dr. Ivan Bolanča. He is associate professor at the Medical School University of Zagreb, Croatia. He is a gynecologist, subspecialist in human reproduction, gynecological endocrinology, and menopause at the Sestre Milosrdnica University Hospital Center in Zagreb. He is the vice president of Croatian Menopausal Society and a board member of the Croatian Society for Human Reproduction and Gynecological Endocrinology. Dr. Bolanča is an active member of national and international professional societies, has lectured at numerous congresses, and regularly publishes topics in reproductive medicine and women's health. Ivan will take us through the topic from hot flashes to fat mass, how menopausal hormone treatment shapes body composition, linking hormone therapy to fundamental changes in women's metabolic health. Dr. Bolanča, the floor is yours. We are also eager to hear your perspective on this fascinating topic.
Thank you very much. Good afternoon, everyone. As Professor Šprem already told, my name is Ivan Bolanča. I'm a gynecologist and reproductive medicine specialist from Zagreb. It's really a pleasure to be with you today on this webinar. So we usually think about menopausal hormone therapy as a treatment only for hot flashes or night sweats or sleep problems. In this talk, I would like to extend this view or to address some other things. How does estrogen loss and its replacement reshape body composition and metabolic health? So we'll move from the mechanisms that we learned from the basic science to clinical data, and finally to show how guidelines and our institution tell us how to real-world practice should change according to it. So menopause marks a systemic, not only reproductive transition. With estrogen loss, with alters thermoregulation, lipid metabolism, and muscle function, as Davorka already told us. So even when this scale or kilos are quite stable, we still tend to expand our visceral and hepatic fat. So that's why we need to think about menopause not as a metabolic event, not only as the last menstrual period. So clinically, after the menopause, we see a steep rise in central obesity, insulin resistance, metabolic syndrome. We know for a fact that within about 10 years, roughly half the women will meet criteria for metabolic syndrome. And the consequences of WHI study or WHI scare left many of women untreated in this critical period of time, or critical, as now we say, window of opportunity maybe. So modern evidence is again repositioning MHT or menopausal hormone therapy as potential metabolic stabilizer, not only just symptom relief drug. This is something we know from the basics from medical school. Before menopause, women typically have gynoid glutofemoral fat pattern, whereas men and postmenopausal women show different android visceral patterns. The main driver of this sexual dimorphism is driven by estrogen receptor alpha. Beta, on contrary, has more modest, not even completely clear role in this topic. With menopause, we can see a rapid shift from gynoid to android fat without a necessary major weight change. So it is more redistribution and less about kilos. The problem is Davorka already told us, and it's not only the visceral fat is different fat. It's not just more fat, it's more fibrotic, more inflamed, more lipolytic than subcutaneous fat. And furthermore, through the portal vein, it exposes the liver to free fatty acid, to cytokines, which promote steatosis, dyslipidemia, and finally insulin resistance. This is why just a small increase in visceral fat can be much more dangerous than the same amount in some other areas like hips and thighs. In contrast, glutofemoral subcutaneous fat can expand healthily via hyperplasia with low fibrosis, low inflammatory tone, and it acts like some kind of safe energy buffer. Higher glutofemoral subcutaneous fat mass is actually associated with lower cardiometabolic risk at the same BMI. Premenopausal women have more lipid activity and triglyceride storage in this subcutaneous fat, and estrogen help women to maintain this protective storage pattern. Estrogen receptor alpha is metabolically active, works in predominantly metabolic active depots, and is closely linked to insulin sensitivity and inflammation. We know it from the basic science. Mice that lack estrogen receptor alpha become viscerally obese, insulin resistant, and hypertriglyceridemic, even on a complete normal low caloric diet. And the same is for humans with estrogen receptor alpha or aromatase deficiency. Looks very similar clinically. So across all the species, this estrogen receptor alpha clearly emerged as a master regulator of visceral obesity and systemic metabolic homeostasis. Genetic studies show that polymorphism of estrogen receptor alpha different variants are associated with higher waist to hip ratio and more visceral fat in women. Again, deficient mice develop visceral obesity and full metabolic syndrome, which completely mirrors the same human association. So this genetic data can even help us to understand why some women are particularly prone to central fat and metabolic syndrome after menopause, some other are not. So what we know today is that estrogen receptor alpha acts on two levels, centrally in the hypothalamus and peripherally in the adipose tissue. If we delete hypothalamic estrogen receptor alpha, animals overtreat less, but still develop visceral obesity due to reduced energy expenditure and altered sympathetic outflow. On the other hand, if we delete adipocyte estrogen receptor alpha, they can develop disproportionate visceral fat and local insulin resistance, even with normal appetite. And we build menopausal hormone therapy could or might restore both layers of this control. Glutofemoral subcutaneous fat has a higher alpha 2 to beta adrenergic receptor ratio. So the basal lipolysis is low and free fatty acid spillover is completely reduced, which is favoring safe fat storage. Estrogen can upregulate this alpha signaling in subcutaneous deposit limits, but without fully blocking and without lipolysis in visceral tissue. And when women lack of estrogen, when it is deficient, this lipolysis becomes completely uncontrolled. Fasting free fatty acids rise, and fat is redirected to liver and muscle, which contributes in the end to insulin resistance. Now, when we put this everything together, we can say that loss of estradiol promotes visceral and hepatic fat deposition without independently of chronological aging. Lean mass and mitochondrial efficiency decline, resting expenditure falls, and cytokines from this visceral fat drives insulin resistance and non-alcoholic fatty liver disease. Again, we think that MHT, menopausal hormone therapy, could help restore this oxidative balance and limit fat storage. It can slow the slide rather than reversing it completely. Clinically, this explains why many women develop so-called normal weight metabolic obesity. This means that BMI is normal, but visceral and hepatic fat are high. Subcutaneous storage capacity shrinks, so lipids are diverted to ectopic depots where they become toxic. Early menopausal hormone therapy has possible potential to limit this or delay this distribution, so in somehow to put a brake on the process rather than is acting like a weight loss drug. Today we know that route of administration matters. We all know that it's completely different oral estradiol or CEE and transdermal completely has different metabolism. Oral need to go this first liver passage, increasing triglycerides, increasing sex hormone binding globulin and various hepatic proteins, even though including some of coagulation factors. That's why, on contrary, transdermal, of course, avoid this first liver passage. So we should bear in mind when first treating our patients, and we will find more when we want to introduce estradiol, we will try to find more metabolic neutral. It's transdermal. On the other hand, we should bear it in mind when analyzing data from different studies, because we will find different results from the similar conducted studies. This is one of the key why results are different. Next component, of course, progestogens. They can either preserve or undermine all those estrogen benefits. So when we think about MHT regimen and when analyzing data, we should also bear in mind not just which estrogen, but also which progestogen. Now we have to see whether clinical data, solid clinical data, can support this or what mechanisms predict. So the obvious next question is not the real data clinical support, but also on what's the impact on real world data. So this first trial I would like to show you is classical trial, 62 early postmenopausal women randomized to combined estrogen progestin or placebo for 2 years. In this study, MHT prevented the increase in abdominal central fat, what we saw in the placebo group, without major changes in total fat or lean mass. So already here we can see the pattern. This is composition shift more than weight loss or weight change. Seitz and colleagues performed 2-year randomized double-blind placebo-controlled trial with oral CEE and MPA, and they used CT, DEX, and ergochemic lamps and found no significant difference in visceral fat changes and only modest effect on insulin sensitivity between those two groups. Now, this study shows that not every regimen is the same and not every gives dramatic body composition changes, but importantly, there is no signal for any harm or any excess visceral fat, although metabolically this is not favorable composition. So I remind you, CEE plus MPA. This is one Chen and colleagues published a study. This is actually WHI sub-study. which is important because of its size. Over 800 women randomized to CE plus MPA or placebo, and it showed small changes in regional composition, but without clinically meaningful weight gain with CE and MPA over several years. So important is that in this population that created the biggest fear, so WHI fear, we didn't see any obesity gain pattern among those patients, although, as I said before, this is not ideal composition of MHT as now today we believe it should be. Rubinov's early postmenopausal study followed 63 women on MHT against no users and looked at weight, body composition, and food intake. So MHT did not cause any relevant weight gain, and it was associated with slightly more favorable, less abdominal fat distribution. And again, this supports the idea that MHT is weight neutral and may even blunt centralization of fat. In this prospective study with almost 300 women combined MHT, it produced a small reduction in trunk to extremity fat ratio. Total body percentage slightly changed, barely, but fat was shifted little away from the trunk, which is, we already heard, important. So effects are not huge, they are modest, but they go in the right direction, less central, more peripheral fat. Here we can see comparative study of classical MHT and Tibolone over 6 months. Tibolone increased lean mass, reduced total fat mass, while conventional MHT had neutral to mildly favorable effects. Evans and colleagues randomized older women to exercise MHT, both or control without any intervention, and measured body composition, insulin resistivity, and VO2 max. The biggest fat mass reduction came from structured exercise, but MHT added an extra 3 kilogram fat loss compared with exercise alone. So lifestyle is the main tool, but MHT in this group showed that it can enhance the metabolic benefits when compared only with training. So as Davorka say, we should encourage our patients to train more. This longitudinal CT study followed women through early menopause and measured intra-abdominal fat, and visceral adipose tissue clearly increased across the transition, but women on MHT had a smaller gain in adipose tissue, and this is another piece of evidence that MHT attenuates rather than causes, as talked before, the central fat shift. Another study, 2-year follow-up, MHT preserved bone mass while moderating fat accumulation. It can nicely show that bone, fat, and lean mass form, in a way, integrated system, and that MHT can modulate all the three together. Again, no evidence that hormones simply add fat. This is another one cross-sectional study, obese postmenopausal women. CT and glycemic clamps used to compare MHT users and non-user. Despite similar BMI, MHT users had significantly less visceral fat and similar or slightly better insulin sensitivity per kilogram of lean mass. So even in the real world, obese women, MHT is associated with more favorable fat distribution. They also allows cohort 1 of the strongest data sets. Over 1,000 participants aged 50 to 80 with analyzing of body composition. And they show that current MHT users had lower total fat, less android fat, less visceral fat, and never users, while former users lost much of that benefit after stopping. That's why we need to closely monitor all those patients with stop of MHT and shouldn't stop it without important reason. MHT use is compatible with a leaner, less central fat pattern than non-users. Costa's more recent small perspective study used low-dose continuous estradiol plus timegastone over 6 months, and they show that MHT attenuates the age-related increase in total fat and reduced fat centralization compared with controls. So even in this modern low dose, maybe too low regimens, we still see the same signal. MHT acts as a brake, not as accelerator of fat gain. Munoz and colleagues looked at fat distribution and insulin sensitivity in early postmenopausal women with or without MHT. And they show that MHT users had lower visceral adipose tissue and liver fat, and the relationship between lean mass and insulin sensitivity was more better in this group. In other words, MHT seemed to improve not just amount, but also the metabolic quality of lean tissue. So this slide summarizes what the major societies say about MHT and body composition. First, NMMS, they clearly state that hormone therapy does not make women gain weight, and that users often gain slightly less weight than non-users. There is some attenuation in abdominal fat gain and improvement in the metabolic profile, but of course, hormone therapy should not be used as a weight loss therapy. Indication still remains menopausal symptoms and bone loss. IMS message is almost very similar. Randomized data do not show relevant weight gain with MHT. Several studies even suggest less abdominal and possible visceral fat and better preservation of lean mass, particularly when therapy is started early. But again, this is metabolic bonus, not primary reason for prescribing. So MHT is not an anti-obesity drug. EMAS is very clear. The main tool for weight and visceral fat are lifestyle interventions. They do not recommend, again, MHT as an anti-obesity therapy. However, they do support using MHT in symptomatic obese women, which is quite novelty as comparing to older guidelines, preferably with transdermal estrogen because of lower thrombotic and cardiovascular risk. So overall, all the guidelines are aligned. MHT is neutral or slightly beneficial for body composition, but it's not a slimming treatment, of course. One slide about non-hormonal options, such as fezolinetant. They're, of course, very effective for vasomotor symptoms, but they do not change body fat distribution, muscle mass, insulin sensitivity. They treat hot flashes only. And this is fundamental difference from estrogen. So here is the synthesis. Estrogen and estrogen receptor alpha direct energy into subcutaneous safe depot and restrain visceral and ectopic fat. Menopause is therefore a metabolic turning point even when BMI is stable. So using of MHT, it's not causing significant weight gain. Trials in cohort, several studies show neutral weight, but quality better composition, less visceral fat, more lean mass, and healthier metabolic profile. And for the last slide, let me please finish my colleagues and friends with 3 simple messages. First, menopause is not only the end of menstruation, it's a metabolic turning point. This is a period when visceral and hepatic fat can silently accumulate even when body mass stay the same. Second, contrary to what many of our patients and colleagues still believe, MHT does not cause any meaningful weight gain. At least it slows the shift towards visceral fat and helps preserve lean mass, especially when we use modern transdermal estradiol and metabolically neutral progestogens. And third, withholding or refusing to prescribe MHT in a symptomatic, otherwise low-risk, healthy patients is also a therapeutical choice. And it has a cost in terms of quality of life and potentially long-term metabolic health. So perhaps the key question is not why should I start or why would I start MHT, but rather in this woman with the risks and symptoms, what is the risk if I don't prescribe the therapy? And with this slide, I would like to thank you very much for your attention.
Thank you very much, Dr. Bolanča, for sharing such a clear and engaging presentation. Of course, your expertise and perspective are truly valuable to everyone, I'm sure, in attendance. Now it's time for your questions, folks. So thank you for all questions you put in question and answer area. Hope we will see more. And for the beginning, I will put some questions for Davorka, the first question. So please, Davorka, if you can tell us, do women come to you more often asking whether they will gain weight during menopause, or do they usually come after they have already gained weight and are seeking help?
Thank you, Marina. Well, unfortunately, they come after, how we say the ship has sailed. So I don't think that we prepare enough ourselves, our families, and our patients for what's coming. And usually they come when they already have obesity, which is, I'll remind you, a diagnosis. So basically, then we have two things together. One of them is obesity as well, with all the complications going together with menopause, which poses a big problem. So unfortunately, they come after they already gain weight.
Thank you very much. And my second question is, in your opinion, which is more beneficial for women in menopause, aerobic exercise or strength training? And how do you see their roles differing in weight management and overall metabolic health?
Well, I would, if I can choose one, I think that aerobic part we have if we are, active in life. So if you go to buy groceries, you have some aerobic point, but not the strength, not that much. It depends on how much you buy, of course. But I think that strength exercise is something which is really, giving us the whole package of mass, which is good, which is protecting us. So muscle mass, something that we didn't mention maybe now because of the time frame, but also if you have muscle mass, if you are mobile, then all the falls in the osteoporosis, there's a lower chance of getting osteoporotic fracture. So basically, I think that muscle mass is something that protects us. We will get it from aerobic as well. Although I think that aerobic capacity and going to this VO max 2, which is something that I learned in sports, is hard to achieve in menopause. So I would always, somehow maybe, encourage a little bit more strength, because it's we always think that women at some age shouldn't do it. They should, of course, it depends on the weights they take, but some kind of strength can be even with patients who have joint problems. Even if you have joint problems, then you have to have muscle to protect the joints. But even osteoarthritis and all those diseases that frequently come in menopause, there are some exercises that you can do, even isomotoric. So there are some exercises that can be, tailored to specific patient. This is why I always say that individualization is important. But there are some things that you can do even with strength.
Thank you, Davorka. So what do you think? Which do you consider more important for weight management in menopause? Nutrition or exercise?
When we talk about obesity, we say that around 80% goes on nutrition and 20% exercise, especially if you have obesity. So I think that we always say that you lose or get weight in your plate, and you remain healthy in the gym. So I think that around 80% would be food and what you do with it, and 20% would be exercise. Of course, if you do the exercise, then all this metabolic entourage of your body will be better, would be more, more promising. But I would say food is more important.
And one question from the audience, Julia Rojas say, how much protein intake would be adequate? Would it be a certain amount in grams each day or per week?
There are some numbers. Usually it's 1 to 1.2 grams per kilo per day for women in menopause. If you want to lose weight, then it's going up to 1.6 grams per kilo per day. And if you're really physically active, even in menopause, it goes to 2 grams per kilo per day. But around 1.5, I would say it's enough. And it should be taken every day, because if you're doing exercise, the muscle is growing 44 hours after the exercise. So basically, if you do it 2 to 3 times a week, the muscle is growing all the time, because you're all the time, chasing some of the exercise you did. So I guess it would be daily.
So one interesting question from Nasrin. She or he said that thanks for the wonderful discussion. And if the patient has osteoarthritis and exercise is very difficult for her, so can she take semaglutide injections instead?
It's no instead. I don't think that there is a disease where you cannot do some exercise. I mean, we see people in ICU and therapy is going around. I mean, you know how we lose muscle mass and doing some exercise, which is not something that we would consider exercise. So I think that it's, the one who wants find a way, the one who doesn't want finds an excuse. Definitely it's not the same, and the approach should be to each person, but with every disease there are some things that you can do.
Okay, so now for Eva, please rest, Davorka, for a while. Just few questions for Ivan, because they are regarding hormone replacement treatment, and maybe we should start with one general question from Eltiola Troka. She said, which treatment regimen do you recommend as hormone replacement treatment in menopause? Oral or either transdermal, or regarding the obesity? I guess so.
I think all the studies show that combination of transdermal estrogen and micronized progesterone taken orally is the best possible combination for addressing all the benefits of MHT. That means safely use of estrogen and micronized progesterone, which is metabolically neutral. Even furthermore, if you use micronized progesterone orally, there is even more central benefits over GABA receptors, so reducing problems with sleep during the night. So I think this is the best combination. So transdermally and micronized progesterone perorally.
Yes, it's very popular today. So the next question, which is followed to the first question from Ivana Oborna, as an effect of estrogen is so positive, for how long do you recommend to treat postmenopausal women? Is there any age limit?
What we know today for a fact, and what all other theory and all the professional societies says that we know for a fact when we need to introduce this therapy. So window of opportunity is within 10 years from the last menstrual period and before 60 years of age. And we don't know how long should, so we don't have age limit when we need to stop it. Older recommendations for 5 years, but we don't consider it anymore as crucial. So now we would say, as much as you don't have contraindications and feel up to it, don't stop.
Yes, you are right. According to the new NAMS position statement and guidelines from 2022, there is no right time to stop hormone replacement treatment. So we can use it after 60 and more, especially in those who have persistent symptoms and who are healthy and not obese, of course, obviously, and with a lower risk of cardiovascular diseases and breast cancer. So in those patients, we can use longer for after 65 or 70 years. We can use low dose preparations, of course, or we can use the combination which you proposed before, transdermal estrogens plus micronized progesterone. You're right. Davorka, there is some question about GLPs, of course, because they are very popular now. Would you recommend GLPs? This is the question from Shashi Prasad. Would you recommend GLP-1 in women who are not very obese or may have normal BMI, but has more visceral fat?
It's very difficult to measure visceral fat. That's something that we know. We cannot only rely on, I see my belly, so I have visceral fat. The exercise is something that we do more in sports medicine, but not in a daily routine. There is a lot of talking today, and I think that the question is concerning that. It's the microdosing. Why is it important? Because there are some drugs, primarily liraglutide and semaglutide, who showed clear cardiovascular protection. So even when we talk about those medications, you should, as I already said, choose wisely and choose those who do the cardiovascular protection. So microdosing is something that we talk a lot, but we really don't know yet what we are doing. Is the dose enough? So it would be the dose that you usually use for titrating to skip the side effects. I think that it will take time to show it. I would say it's good, but I don't have the science to back me up. This is just my impression, and if I see the mechanism and everything that happens, that's something that I would expect to be good in the seeing of the cardiovascular protection. Probably this microdosing will be shown in the next couple of years. For now, we don't have the science to back us up.
One question you mentioned in your presentation from Irina Orishko. Do you have any data on whether GLPs leads to greater weight reduction in patients who are receiving menopausal hormone treatment? So if they use both.
Even me. I think that I told you it's the match made in heaven. So I think that MHT is not weight reduction therapy, but helps to remain the state that we were in. Maybe a little bit in favor of losing weight, but not statistically great. And GLPs the mechanism is completely different and do it pretty strongly. So I think that the combination is good. Definitely, going along very, very, very well. Ivan, do you agree?
Of course, Davorka, I agree completely. So we need to bear in mind that MHT is not losing weight therapy. So GLPs are, but MHT is more like reshaping a little bit, and all other benefits which bring us estrogen. So it's not weight losing therapy.
Thank you so much. There are some general questions about menopausal hormone treatment. Maybe we can answer to those. Irena Makiewicz asked, is it hormonal replacement possible or even better already in perimenopause? So when should we start?
It's not an easy question. The MHT is prescribed main indications vasomotor symptoms. All those benefits we talked about are added benefits. So it's not actually for premenopausal patients or perimenopausal patients, but however, for special patients, individualized, we can use them, and we need to bear in mind that first we are losing progesterone. So when in premenopause or perimenopause, women are all usually flushed with estrogen. So in this case, we need to add more progesterone. So micronized is good start to MHT without estrogen. And furthermore, when ovaries are declining in their work, so we can introduce then estrogen. So my answer is yes, but carefully.
Ivan, one very important question in light of the use of new generations of non-hormonal treatment options. So maybe you can answer to us, how effective are non-hormonal treatments in maintaining metabolic health in patients who cannot receive menopausal hormone treatment?
It's not an easy question. Lack of estrogen is a crucial problem for women. So we need to find, in those patients who are not candidates for estrogen therapy, we have to find a solution for each one of the problems. So Today we have drug fezolinetant, which is used for non-hormonal options for vasomotor symptoms, like hot flashes, night sweats, and we can use it in those patients. But okay, so we need to bear in mind that we don't have studies for each group of patient, but sometimes we can use it in selected groups and so on, so on. So we can address these issues with fezolinetant. Like vaginal dryness, we can use with some kind of remedies for topic use. We can use vaginal estrogen, which is not contraindicated in most of the patients. So we need to address every issue with different solution. Unfortunately, when estrogen is covering all those problems, and this patient have to be more precise and address every one of these problems.
Thank you so much, Ivan and Davorka, for your answers. We have many questions more to answer, and we will do it later because we are around the end of our webinar today. So for the conclusion, thank you to our speakers and our audience for joining us today. We have gained valuable insight, I hope so, into how hormonal changes and lifestyle factors and therapeutic choices may intersect to shape weight and metabolic health during perimenopause and menopause. Together, they offer, I think, comprehensive and practical perspective on managing weight and metabolism in menopause. So maybe the key takeaway message will be that weight gain after 45 is not inevitable. And with the proper guidance, proper treatment, and proper support, women can maintain both health and quality of life. On behalf of EMAS, I'd like to thank you for participating in this webinar, in our inaugural webinar in this new monthly series. And we are looking forward to seeing you again next month as we continue to share knowledge and strengthen collaboration between different disciplines in terms of menopausal care. Thank you so much and see you soon. Ciao.
Thank you.
Thank you very much. Bye. Bye.